make good use of your time. So we will review quickly the lymphoma trials. We're going to first start with Polarix. Next slide, please. So, the question that was asked was, does the addition of palatuzumab vedotin with rituximab, cyclophosphamide, and doxorubicin and prednisone provide benefit over standard of care, which all of us know is R-CHOP, to patients with diffuse large B-cell lymphoma without prior treatment? Next slide. So, Polarix is a randomized phase 3 trial that looked at the addition of palatuzumab vedotin, which is a ADC targeting CD19, which is ubiquitously expressed on all diffuse large B-cell lymphomas. And in this trial, they randomized about 880 patients, and they were patients who had never been treated with intermediate to high IPI score. And they were stratified based on bulky disease, high IPI score, and geographically where they were diagnosed. And they're randomized in a 1-to-1 fashion, and they compared, again, R-CHOP, which is standard of care, to POLA-R-CHP, with the primary endpoint being investigator-assessed primary progression-free survival. But they also looked at event-free survival, complete response rates, and OS. Of note, they had about 2.5 years of follow-up, and it was the data cutoff was in June of 2021. Next slide. So the baseline characteristics of the patient was really very even. The average age was about 65. Majority of the patients had advanced disease, stage 3, stage 4 disease. The cells of origin were, again, balanced well. There were a couple of people with double and triple hit mutations, and also MYC and BCL2 expression. Next slide. So here's the efficacy data. It looks at both the PFS, the EFS, and the OS. So at 24 months, what they were able to show was about a 6.5% increase in PFS in the PRCH ape arm. And so initially, the curves at 6 months weren't, they were on top of each other, but they began to split as it went on. And same thing with the event-free survival. Event-free survival is also initially overlapping at 6 months, but as time went on, the curves began to separate a little bit. But of note, there really was no survival advantage that was noted in this trial. Next slide. And here's a slightly deeper dive in the disease-free survival. Again, at 24 months, the rates were about 6% better, but more importantly, it was more CRs. So the CR was improved in the PRCHP arm compared to R-CHOP. But again, no difference in overall survival was noted, and the p-value was 0.75. The disease-free survival did indicate that people that achieved a CR with this combination were more likely to maintain remission compared to those treated with conventional R-CHOP. Next slide. So, one way to measure this is how many people ended up getting treated after they progressed. And at the data cutoff, there is about a 8% advantage in people requiring more treatment in the R-CHOP arm compared to the PRCHP arm, with about 22.5% of people in the trial arm compared to the comparator arm. And we're listed below are just what therapies they have. Some people got radiotherapy, some people got transplants, some people even went on to get CAR T therapy. Next slide. One of the things they were also hoping to show with this trial was, is there any difference in AE, specifically neuropathy that is always feared with vincristine? So interestingly enough, all across the board, the AEs were almost identical. All AEs are about the same. Significant grade 3 or 4 AEs are about the same. What they called serious AEs are about the same. Discontinuation because of was about the same at about 4.5%. And dose reduction was maybe favored slightly PCR, but not much. Next slide. And so this is just another forest plot that looks at a different way to compare these adverse events. Again, almost identical. All grade AEs were very, very similar at about 53%. The grade 3s and 4s were also very similar. And again, we hypothesized there might be less neuropathy, but that did not seem to be the case with this cocktail. Next slide. So the summary is, the good news is this is the really first positive trial in frontline settings in diffuse large B-cell lymphoma in almost 2 decades. POLA-R-CHP did increase PFS and EFS in these intermediate and the high-risk previously untreated patients compared to standard of care. At 2 years, there's about a 27% reduction in relative risk of progression or death versus R-CHOP. But of note, there was no true survival advantage noted yet. But again, this is kind of only about 2.5-year follow-up, and we'll need to follow up to 5 years to really see if there's any OS advantage. There was also a pretty comparable safety profile for them. So you're not sacrificing any more toxicities for this improved PFS and EFS. Next slide. So the impact is really the use of, I think, PALO plus R-CHP does provide benefit in patients with diffuse large B-cell lymphoma compared to people with standard of care. Of course, we'll need to see what the FDA thinks about this and whether this will be approved first-line regimen in the future. Next slide. The next trial we look at is the REMIND-2 trial. Go on, next slide. So the REMIND-2 trial looked at tafasitamab in combination with lenalidomide for improved outcomes in patients with relapsed refractory diffuse large B-cell lymphoma. Of note, this was actually a pragmatic or observational real-world evidence retrospective cohort trial. And so what they're able to do is compare the outcomes of people with L-MIND, and which was the trial that got tafasitamab improved in the first place, compared with matched controls based on the NCCN ESMO recommended therapies in patients that were not eligible for stem cell transplant in this refractory relapsed diffuse large cell lymphoma group. Next slide. So again, a little bit of a complicated slide for these pragmatic trials always are. What they were able to do for the eligibility, they were able to look at data of about 3,400 patients. All patients had to be relapsed refractory, had had more than 2 lines of therapy, and ineligible for any more transplants, meaning they could have had a stem cell transplant already, but ineligible for either an allo transplant or a auto transplant as the next line of therapy. They did include patients that were primary refractory to this, and this is always a slightly more different category of patients to treat. What they're able to do is, with that matching criteria, they're able to find 81 patients from their original L-MIND trial, and they were able to use that as a comparator arm going forward. So the goal of this trial was to look at overall survival, overall response rates, and progression-free survival. And the comparator arms in this were POLA-BR, or what I call PBR, R-squared, and actually CAR T therapy. Next slide. So what they do in these cohort trials is they really try to match these patients by using something called the propensity score. And with this, they had 6 matching covariates, and they wanted to almost nearly 1-to-1 match them exactly with patients from these other cohorts that were from the real world setting. And so initially, again, they had about 3,400 patients in the cohort arm. And then they looked at the L-MIND study and all the eligibility criteria for the L-MIND. And all those patients had at least have 6 months of follow-up. And with that, you had 76 patients in the TAFA-LEN arm, 92 patients in the PBR arm, 92 in the R-squared arm, and 140 in the CAR T arm. And then they, again, matched them with the 6 covariates and ended up whittling these numbers down to 24 in the PBR arm, 33 in the R-squared arm, and 37 in the CAR T arm. Next slide. So this is just the high degree of balance that was achieved. So in the first column is the Tafa-Len arm compared to the Pola-BR arm. And you can see they're very well matched for primary refractoriness, refractoriness to the last line of therapy, age greater than 70, more than 2 or 3 lines of therapy, and an ECOG score greater than 2. And they're actually pretty similarly matched for the other 2 arms as well, for the R-squared arm and the CAR-T arm as well. Next slide. So I thought this was interesting. You know, the primary endpoint was overall survival, and they compared TAF-Len, again, this is real world evidence, compared to Pola-BR. And in the TAF-Len arm, you know, the median OS was, or probability, I should say, of OS was about 20.1 months compared to 7.2 months in the PBR arm. Also, if you looked at the Tafa-Len versus R-squared, again, the probability of OS was again about 24.6 months versus 7.4 months. Next slide. Even when compared to CAR-T, I thought it was pretty interesting that there really wasn't much of a difference in the probability of OS. Now I do think this is a little bit skewed because a lot of times, you know, patients that go to CAR-T or aren't eligible for CAR-T tend to be a little bit, you know, sicker of a patient population. But again, they really try to match them based on the covariance. And what they determined was there was no difference in OS with the Tafa-Len versus the CAR-T. Next slide. Here's some secondary endpoints which looked at, again, overall responses and complete responses. Again, and the Tafa-Len arm versus Pola-BR arm, both had pretty good response rates of about 60% or so, and there was no difference in, they found out in the response rates. But in the R-squared arm, there were differences. The overall response rates were about 63 in the Tafa-Len arm versus about 30% in the R-squared arm. Same with CR rates, about 40% in the Tafa-Len arm versus about 15% in the R-squared arm. Lastly, in the Tafa versus CAR-T, Tafa looked a little bit inferior to CAR-T, but again, there's no difference in the, or no statistical difference in the values. Next slide. Again, some more secondary endpoints with progression-free survival and duration of response. Again, it looks, the Tafa-Len arm versus PBR arm had a little bit more PFS, but again, did not meet statistical significance. But the Tafa and Len versus R-squared, again, did meet statistical significance. So CAR-T also did not meet significance. So only PFS and DOR were better in the Tafa-Len arm versus R-squared arm. Next slide. So in summary, in this retrospective cohort analysis, there was a difference in probability of OS for Tafa versus Len versus Pola-BR and R-squared in these patients that were relapse refractory who were ineligible for transplant. Both were statistically significant and both had a very impressive p-value. There was no difference seen in Tafa-Len versus CAR-T. And there were a little bit of a difference in response rates, but only in Tafa-Len versus R-squared. So, you know, in July 20, they did improve Tafa in combination with R-squared for patients with relapse refractory lymphoma. You know, to me, this is a pragmatic trial, a retrospective cohort trial. It really doesn't answer the question, but it does give good hints on what might be a good clinical trial looking at a phase 3 trial going forward. Next slide. So this is the impact slide. The use of Tafa versus Len provides benefit to patients with diffuse large B-cell lymphoma in the second-line setting. And it really offers another valuable treatment options for these patients who are ineligible for a stem cell transplant. Next slide. Well, I think as most of us know, at ASH, there was a lot of excitement about CAR-T therapy in diffuse large B-cell setting, lymphomas in the second-line setting. And there were actually 3 trials presented at ASH. We're going to be focusing more on ZUMA-7 because that has the longest data and the longest follow-up. But there's actually 2 other trials. One was Transform and one was, it was Belinda. Now, Belinda ended up being a negative trial, but it's because it had a very complicated schema, I think, where people could get 2 or 3 rounds of different rounds of induction chemotherapy if they did not meet responses. And this will be explained more in the next couple of slides. So next slide, please. So the ZUMA-7 clinical trial tried to answer the question, does a use of CAR T therapy in the second-line setting provide patients benefit over standard of care patients, when either patients that are primary refractory or relapsed within less than 12 months in large cell lymphomas? Of note, this did not answer the question in patients that had late relapses. This is really for a very specific group of patients who are known to be have poor responses anyways. Next slide. So here is the schema for it. What it would, the inclusion criteria is very specific. It would be patients with a large cell lymphoma who were either primary refractory or relapsed within 12 months of having an adequate chemoimmunotherapy-based regimen, and they had to have received an anthracycline in it. All these patients had to be able to undergo a stem cell transplant, and if so, they were randomized in 1-to-1 fashion. Now, of note, in the ZUMA-7 trial, they did not get any bridging therapy. So unlike the Transform trial, they got bridging therapy, and same with the Belinda, you're able to get bridging therapy. In the ZUMA trial, you either went straight to CAR T therapy or straight to a platinum-based chemotherapy and then to stem cell transplant. The conditioning regimen for the ZUMA trial was cyclophosphamide and fludarabine. So they tried to lymphodeplete them, and they could not have any other chemoimmunotherapy in between. About 360 patients enrolled in this trial, 180 in the axicell arm and about 179 in the standard of care arm. And again, standard of care, you could have Rituxan and then GDP, Rituxan DHAP, Rituxan RIs, or Rituxan ESHAP. So they had to get a platinum chemotherapy, and then it was really dealer's choice. And of those, only about 64 actually had either a CR/PR, meaning responded, and were able to make it to a stem cell transplant. All the other non-responders came off protocol, and about half of those responders actually went on CAR T therapy at that time. Next slide. So again, here's kind of the ongoing schema. 180 in the axicell arm, 179 in the standard of care arm. Of that 180, about 171 were able to undergo leukapheresis, and then 172 went on to receive the lymphodepleting chemotherapy, and 170 ended up receiving the infusion. In the standard of care arm, about 168 were able to get at least one cycle of salvage platinum-based chemotherapy. Of that 168, only 80 responded. And of that 80, only 69 were able to undergo leukapheresis. And of those, only 64 went on to get stem cell transplant. So in all, about 36% of patients were able to go on and get the auto transplant. Next slide. So the baseline characteristics for all the patients were very equal. Again, these are stage 3 to stage 4 patients with a relatively high IPI score. Again, a very difficult to treat patient population. A lot of these patients were primary refractory, meaning they didn't completely respond to the first line therapy. And about, a little more than a quarter were about relapse within a year. There were some patients that had double and triple hit lymphomas, some expressors and some with just some MYC rearrangements. And about half the people had an elevated LDH. Next slide. So here's the efficacy curves, and these are what I think grabbed a lot of people's attention. So almost right away, you see the curves separate. And this is the event-free survival curves, and it was a pretty robust. It was the event-free survival in the standard of care arm was about 2 months versus 8.3 months in the axicell arm. And even at 2 years of follow-up, the 24 months of follow-up, about 40.5% of patients were still event-free, compared to only about 16% of patients in the standard of care arm. And this is pretty encouraging because we just saw some data from ZUMA-1 that now has 5-year data that does show there's now overall survival. So we're really hoping that these people or these patients that are in long-term remission right here will continue to be in remission. Next slide. Here's just the efficacy by subgroups. Pretty much every subgroup it was more efficacious in. Whether you were greater than 65 or less than 65, there was still a advantage. Whether you were primary refractory or relapsed within 12 months, still an advantage. And people with the high-grade lymphomas, including double and triple hit, there was certainly an advantage compared to the standard of care. Next slide. Response rates were also significantly more improved in the axi-cel arm, with CRs about 65% compared to 32%. Stable disease, not a lot of stable disease in the arm, but that's okay. We're looking for the responses. And now of note, there is no OS yet, not enough time has passed, I believe. And also about 56% of people on the standard of care arm ended up getting CAR T therapy as an approved third-line therapy. So that will probably confound and make OS a little bit harder to achieve, but we do believe there will be OS in the future. Next slide. So, one of the things that we know and with CAR T is side effects. Are the side effects worth the toxicities to the patient? So here's a breakdown of the side effects, and a lot of these side effects are known. All the side effects with pyrexias, hypotension, diarrhea, leukopenia, were all what we expect with this CAR T therapy. There were some grade 3 or higher events, but of note, there were some grade 5 events as well. So even though we are more experienced in these toxicities now, there are still some grade 5 events that happen, unfortunately. Next slide. And this is what we all fear, at least in the community, the cytokine release storm. Even when patients go get CAR T therapy, they can come back a month later and have delayed CRS. So this is what we kind of fear. And this is what was seen in the trial. Almost uniformly, they all got some degree of CRS with a hypotension, pyrexia, sinus tachycardia. And I think most of us nowadays know how to manage it with either TOCI, steroids and vasopressors. The mean time to onset was about 3 days and duration was about 7 days. We also kind of fear the neurologic complications that can occur. About 60% got some grade of neurologic complication, but thankfully there are no grade 5 complications with this. Next slide. So in summary, I think treatment with axi-cel in second line in this relapsed refractory large cell lymphoma did improve event-free survival. And this is maintained across all subgroups. I do think while they do have their known AEs, there were no new safety concerns. And so this is, I think, an exciting new step for these patients. Next slide. And kind of gets, again, to summarize the impact, I think the use of axi-cel does provide benefit over standard of care for patients with relapsed refractory large cell lymphoma in the second line setting and should be considered for eligible patients. And we'll talk about this more in some of the other sessions, but where does CAR T fit within the community oncology? Because again, I know a lot of community oncologists don't do it ourselves. We have to refer to an academic center to get it done. And go on, please. The last slide we're going to look at is Sequoia. Go ahead. So Sequoia answers the clinical question, does the BTK inhibitor zanubrutinib provide benefit in patients with untreated CLL or SLL? Next slide. So the Sequoia was a multi-cohort open-label phase 3 trial. In order to be on this, at least cohort 1 was phase 3. In order to be eligible for this, you needed to have CLL, SLL, and needed to meet one of the international working group criteria for treatment. We had to say that they're unsuitable for FCR. And there were 3 cohorts. Cohort 1 was patients that did not have DEL-17, by central fish, and these patients were randomized either to zanubrutinib versus what is now the new chlorambucil, which means what everything's getting compared to, BR. Cohort 2 looked at patients with DEL-17, and these patients were treated with monotherapy with zanubrutinib. And cohort 3 looked at the combination of zanubrutinib and venetoclax. The primary endpoints for cohort 1 were PFS by IRC assessment, and secondary endpoints are going to be PFS and ORR and OS as well. Next slide. Here are the characteristics of all these patients. Again, very balanced. There were some DEL-11 patients in this cohort as well as some TP53 patients and unmutated patients as well. Next slide. So here's a PFS data that we see. Initially, again, at the first 6 months, very little change in the PFS, but as time goes on, as they're continued on zanubrutinib, we do see the curves begin to separate. At 24 months, the PFS was 85.5% in the zanubrutinib arm, and only 69% in the comparator arm, which is BR. Next slide. Here's just the PFS by the subgroups, looking at, is there any subgroup that benefited more? Again, the chromosome 11 deletion, kind of a higher risk patients, looks like there was some benefit, and same thing with unmutated patients. So kind of the higher risk groups tend to get more benefit with the BTK inhibitors, and that's not that unexpected. Again, we'll talk about this later in the sessions. Next slide. The AEs in cohort 1 were kind of what we expect. I think it was very interesting that there were some fatal AEs in the BR arm and also in the zanubrutinib arm. So again, we tend to think of these treatments as a little bit of innocuous, but there is unfortunately, some treatment-related AEs that can occur. As with most BTK inhibitors, you can see bleeding and bruising as some of the biggest AEs compared to bendamustine and rituximab. There is also slightly more upper respiratory tract infections, but there tend to be less cytopenias, less neutropenia was seen with the zanubrutinib, less thrombocytopenia, and also less anemia. Go ahead, next slide. Again, here's just a breakdown again of the AEs, looking at zanubrutinib compared to BR. Again, anemia was less, neutropenia was less, thrombocytopenia was less. One of the interesting thing was AFib. That's always a worry for people in the zanubrutinib arm. I thought it was pretty interesting that AFib was also seen in the BR arm, probably mainly due to the patient's age, I would think, as opposed to treatment related. But again, not much difference in AFib. There was obviously a difference in bleeding, and there was some major bleeding that can occur. So that's one of the things that we always worry about with this group of medicines. Next slide. In cohort 2, the patients that had the deletion 17p were just randomized for zanubrutinib. Go ahead. And really, the point of this cohort was really just to see if there was truly benefit to these patients. And we see after about 24, 36 months, so about 90% of patients were still hadn't progressed yet. So the conclusion of cohort number 2 is zanubrutinib remains effective in patients that have deletion 17p. Next slide. And again, cohort 3 was again patients that also had a deletion 17p or TP53 mutated, and these patients were randomized to zanubrutinib with 3 cycles of a loading dose, and then venetoclax in the typical ramp-up cycle fashion. Next slide. Here are the baseline characteristics. Again, this is kind of a high-risk group, patients had del 17 positive. They were IVHG unmutated patients. They all tended to have a complex karyotype. Again, all high-risk features. Next slide. So, the purpose of doing 3 cycles of zanubrutinib before adding the venetoclax is to decrease the likelihood of having tumor lysis. What makes tumor lysis high? As we know, the presence of a very bulky lymph node greater than 10 centimeters, an ALC greater than 25, and lymph node greater than 5 centimeters. When you did the 3 cycles of induction zanubrutinib, you really shifted the paradigm from a third of patients having a very high risk of tumor lysis to about 2/3 being medium risk to only about 2/3 being medium risk, no really high risk tumor lysis patients after the 3 cycles of zanubrutinib. Next slide. This is overall response rates that was seen. Overall, there's about a 14% CR or CRI, about a 77% overall response rates. And so really, this was just a proof of concept. One is that zanubrutinib plus a BCL2 inhibitor, is it a safe and is it effective? Next slide. These are the AEs that we're seeing in this combination. Again, nothing out of the expectation for these BTK inhibitors plus the BCL2 inhibitors. Next slide. So kind of the summary slide for Sequoia. In cohort 1, at a median of about 26 months, there was a significant PFS advantage compared to BR. PFS was also improved in the high-risk groups, which in cohort 1 were the unmutated patients and the del 11 patients. OS was not observed yet because a lot of patients on BR are more eligible to cross over to zanubrutinib. In cohort 2, at the median of about 30 months, zanubrutinib was effective in treating patients with del 17p. And in cohort 3, a very short follow-up, it did look like zanubrutinib and venetoclax resulted in a very high response rates in these high-risk del 17 TP53 patients. There were no new safety signals observed, and the risk of AFib was very minimal. Last slide. So the use of zanubrutinib, either in combination or as monotherapy in frontline setting, does provide benefit. I'm not sure if the audience knows this, but 2 or 3 weeks ago, the NCCN did update their CLL treatment guidelines. They now include zanubrutinib as a preferred regimen in both the first-line setting and also in these high-risk patients. The category was a 2A though, but is now a preferred regimen. And that's it for me.
Wow, yeah, there's a lot going on here, right, on the lymphoma category. So keep the questions coming in the Q&A button. Number of great questions, and Dr. Kalmadi was hitting most of those. Sujit, I don't know if you're on mute right now, but were there any that you wanted to go ahead and introduce to Dr. Schaefer, Dr. Bachani, that you did answer that would be good in the open discussion?
Yeah, I think a couple of things. First question for both Dr. Schaefer and Dr. Bachani. How far do you think we are away from using CAR T in the community setting? A lot of these side effects, I think there are a significant number of community oncologists would be adept at handling them because we have handled side effects in hospital for interleukin when we used to do it. We handle side effects for immunotherapy with steroids. We use the monoclonal antibodies to combat the side effects of immunotherapy. So all of these things that we used to. So far do you think we are away from actually using it in our own office ourselves rather than sending out? Rick?
I mean, personally, I think we're getting closer, Sujit. Like I said, I think the biggest drawback is right now we have to send them to an academic setting or referral setting. And it's not just the side effects they have, but it's the travel that they have to do and a lot of the logistics that they have to do. But you're right, I think a lot of us know how to use TOCI now. We know how to use corticosteroids. We are getting more and more comfortable doing them. So my own gut is we're probably just 1 or 2 years away from really beginning to becoming more and more mainstream. And I think in the future with, CAR T off the shelves or other ways that have lower CRS, that more and more patients will be getting CAR T therapy.
Dr. Vachani?
Yeah, so as an academic physician, I might be slightly biased, but I think the CAR T space will no doubt come onto the community side. Especially the big community oncology sites could definitely do it. The logistics, of course, is a big component. So planning for CAR T way ahead of time, having a FACT certified center, that's not so easy to achieve for a small community setting, but a big community setting, absolutely. I think we are maybe a couple of years to 5 years away from seeing CAR T being performed.
Can you talk to about the supply chain shortages we're running as far as production of these things? And like Joel was optimistically saying, end of 22, we have a car for everybody, and real estate interest rates will be double, -5%, like you said. Can you comment on that in the space of the CAR T and where we'll be in the supply chain shortage by the middle of the year?
Boy, Sujit, I'm kind of the wrong person to talk about.
No.
supply chain shortages.
I was asking Dr. Vachani on that.
Yeah, and might I ask, supply chain shortage of what exactly?
Of production of the CAR T, because here at the Mayo Clinic, they're limited to treating one patient per month. And what they tell me is because of the COVID vaccination, they're using most of the supply to produce the COVID vaccine. So they're running into a significant shortage in the viral vector that they're using, or whatever vector they're using. I'm not too competent to comment on that. We had those similar challenges in not being able to get the production to treat your patients.
Got it. Yeah, just wanted to make sure, because we also have supply chain shortage and other logistical issues with blood transfusions at the same time. So I just wanted to clarify that. So having spoken with some other companies about CAR T trials, as well as on-label CAR T use, they are telling me that they see the shortage going away sometime in the middle of this year, assuming that we don't have another variant coming in. Personally, we ourselves at UAB have seen a big change from 2020 to 2021, and in the last few months as well. Things are easing up back to what they were before. But I still don't think we are where we were in 2020. But again, from everything we are seeing so far and from what I hear from the pharmaceutical side, middle of 2022 will be back.
Okay. So I have a question for you. I've answered most of the questions. So the question for you, which I think is definitely relevant from a community standpoint, can you comment on bleeding risk between these three agents and your current practice of anticoagulation in patients on BTK inhibitors because of the high risk of bleeding that we're seeing?
Is that for Dr. Schaefer?
Yeah.
Yeah, I mean, it's a good question. That's one of the fears that we all have. And I don't know, one of the benefits zanubrutinib has is that you're able to take a PPI with it, and the absorption doesn't change at all. And it, the risk of AFib is less, and really it plateaus after about a year. So it slightly increases, and after a year, we don't see any more increasing risk of AFib. So yes, I mean, all these medicines do have bleeding risks associated with them. I personally think zanubrutinib has a little bit less, although the data, obviously you can't, or you shouldn't compare, the Aspen trials versus Sequoia trials versus the brutinib trial. So again, I personally think it's a little bit less, but it is something you have to worry for. And, we have to talk to the patients. Hey, if all these people are on, not all, but a lot of patients are on Coumadin. Why they're on Coumadin, I'm not sure half the time. The patients don't know half the time. But that increases the bleeding risk itself. So it's just a conversation you have to have with the patients. Really, these people should only be treated if they meet the criteria, meaning they have rapidly progressive disease or getting cytopenias, they have end organ failures from the disease. So we have to treat them with something. And I think putting them on these BTK inhibitors is probably worth the risk, but it's just a conversation you have to have with patients.